Hi, good afternoon. Thank you all for joining us this afternoon here at CSIS to talk about efforts underway here in our city, the District of Columbia, to control HIV/AIDS. Let me say a few words by way of introduction. First of all, there's a number of things I want to call to your attention that are coming up as major activities. On Friday, December 5th at 1 p.m., there will be a session done together with PATH on successes in malaria control in Zambia, an excellent program. That's from 1 to 3 p.m. right here on Friday. We have Secretary Levitt speaking on Friday, December 12th at 2 p.m. here, reflecting on his experiences internationally as Secretary of Health and Human Services. On Monday, January 13th, we'll be joined by Pamela Barnes, President and CEO of the Elizabeth Glaser Pediatric AIDS Foundation, a wonderful organization. It's made many contributions over the years and has dramatically expanded its work in Africa. Pamela will be speaking here on Monday, January 13th at 11 a.m. And former Secretary Tommy Thompson, former Secretary of Health and Human Services Tommy Thompson, who now heads an effort on neglected tropical diseases, will be speaking here on Monday, January 26th at 2:30 p.m. So please join us for those. Now, today is a very special day. First of all, we're putting a focus here on the District of Columbia, and I'll say a few more words about that in a moment. Also, we're joined by a contingent of middle schoolers from Capitol Hill Day School, who I want to offer a special welcome to. Thank you all. We thought this was very appropriate because, as you'll hear from Shannon Hayter, the activities that are underway seek ultimately to connect effectively to the youth within our city here. And so it's very, very important that we have a contingent here, and I'm thrilled that this has been possible, and I want to particularly thank Jason Gray, head of the upper school, and the assistant head of school, and Mary Beth Moore, head of admissions, for helping us pull all of this together today. Thank you very much, Jason, for doing this. It wouldn't have happened without your help. I want to point out also we're joined here today by an employee of CSIS, Deborah Stroman, who joined us a few years ago. Where's Deborah? Deborah Stroman had a career for 26 years as a teacher of 6th grade within the District of Columbia. So, Deborah, thank you so much for coming and being with us today. Now, why D.C.? The reason we've done this is because we live here. We have to be concerned with the epidemic that is in our midst. We've been negligent, I believe, here at CSIS in not coming to this point sooner. We had a task force on HIV/AIDS, a very successful task force that ran for 7 years. Only now, as we launch our Center on Global Health Policy, have we been able to sort of engage the leadership. So the first point is that while we have in our title that we are concerned with global health policy, that does not mean that it's all over there. In fact, the way we define this is we are concerned with the health within our country, and what happens within our country is critically important in shaping our broader engagement within the world on health matters. And we will continue in that vein. We're hoping in the coming year to do many other programs. We're looking to do a program on the reconstruction of health within New Orleans. We're looking to look at some of the immigration and border issues. We may take a look at pockets within the United States which have special problems of poverty and public health. And there are many other areas where we could pursue, and we'd welcome more suggestions in that vein. I think it's very important in this speaker series, in particular and in our other programs, that we continue to integrate important work on public health developments within our country and how those relate to our overall approaches globally. Now, I think we'll hear today that, in fact, much progress has been made in the District of Columbia and much work remains. Another theme that I think you'll hear today is that leadership truly matters. I think we owe a great deal of gratitude to the current mayor, to Mayor Fenty, who has picked this issue up and taken it on in a way that it has not been done before. And we're very grateful to the city administrator and deputy mayor, Dan Tangalerini, who has been as equally committed and passionate on this issue, for coming and being with us today. And he will do the honors of introducing Shannon Hayter Dr. Shannon Hayter, the head of the DC HIV/AIDS activities. Now, leadership really matters. Shannon came here, left the CDC, the Centers for Disease and Prevention Control, came to Washington, has been here for a little bit more than a year, and the impact is already very visible, and we'll hear more about that. This is a city that is turning things around in many different dimensions, and this one has not gone missing. Public health dimension and the HIV/AIDS epidemic which we face, and we'll hear more about that. As I said earlier, connecting with youth is essential, and we'll hear more from Shannon as to the many innovative ways in which she's developed special new programs to connect to youth within the District of Columbia. So with that, let me just turn to Dan and ask him to do the honors. Dan is, as I said, is the city administrator and deputy mayor. He is active in the implementation and movement forward of policy in virtually every area of the city administration. He served previous to that as the District of Columbia's head of the District of Columbia's Department of Transport. He was the interim general manager of the Washington Metro system. He's held many other jobs within the district administration and is a real star within this team that is guiding things now. So Dan, thank you so much for being with us.
Thank you very much, Stephen, and thank you all for being here, and welcome. On behalf of Mayor Adrian Fenty and the citizens of the District of Columbia, I'm here to express my appreciation for your taking an interest in this issue, in the District of Columbia, and frankly in the two together. I think it's also very important that I too recognize a very important group of people that are here, and that is the upper school students of the Capitol Hill Day School. And in particular, there's one very important upper school student who I need to recognize, and that's my daughter, my 11-year-old daughter, Cassandra Rose Tangerlini, who's incredibly embarrassed right now, and would definitely tell me a thing or two about how much she liked this later today. This is an important time, certainly in the world, certainly in the nation, and certainly in the field of HIV/AIDS. And I'm not talking about the fact that it's just the day after World AIDS Day. The fact is that we are at a crossroads. We're certainly at a crossroads politically, we're certainly at a crossroads economically, and in no way is that crossroads more represented than what's going to take place on January 20th here in our nation's capital. We are going to have the honor of paying host to one of the most important ceremonies in democracy, and that's the peaceful transfer of power, of civilian power, from one duly elected president to another. And we're tremendously excited about what that event is going to do for the city. I'm tremendously scared about all the work that it means, certainly for the city. But we're also really excited about the fact that this represents huge opportunities for us, for the nation, and for the world. But while people will focus on the president and the federal government, there's another city here, a city that too frequently is ignored, and one that, frankly, sits astride a global divide of prosperity and poverty. And in few cases does this divide stand in more stark relief than in the case of HIV/AIDS in our city. But so what? I mean, it's easy to point to a problem. In fact, a very smart person once said that the easiest thing to do is to do nothing. The second easiest thing to do is to criticize those who do stuff. The hardest thing to do, frankly, is to do stuff. And that's what the Fenty administration is really all about and is committed to. We're committed to change. We're committed to bridging the divide. We're committed to solving these problems. And that's evidenced, frankly, by our focus on reforming the public school system and the education system because, and this is really important for you to listen to, kids, there is no opportunity without education. We're also committed to doing it when it comes to homelessness, and we've done something incredibly radical and incredibly controversial. We've worked on curing homelessness by giving people homes, and we've done that for 500 of 1,700 most chronically homeless individuals in the city. And we're doing that in HIV/AIDS, and I think the way we want to do it there is, frankly, what Stephen talked about, and that is through strong leadership and focus and energy. Because there is no problem that cannot be solved without strong leadership, without a committed leader focused leader, someone who looks at the problem, breaks it down to its constituent parts, and tries to find solutions for that. And that's why I'm here to introduce a great leader. That leader, of course, is Shannon Hayter, someone who's worked to bridge that divide throughout her incredible career. And just going back over the resume in preparation for this, it would be a great movie someday, and I can't wait to see the movie about Shannon Hayter. From Mississippi to Zimbabwe, from the CDC and the Department of State, and now the District of Columbia, Shannon has been committed to working to give everyone an opportunity to live a healthy and complete life. She's our Senior Deputy Director of the Department of Health, running our HIV/AIDS administration. I'm proud to have the opportunity to serve with her, and I admire her greatly. Dr. Shannon Hayter.
Well, good afternoon, everyone. Good afternoon. All right. I always, when I'm in a federal audience, have to remind people that D.C. proper, we're sort of actually a small southern town. So some of these, like, good morning, good afternoon, we're all used to over here, right? Absolutely. What I want to talk to you today is really sort of the framework of, what I think when I tried to distill it down is high expectations. Really high expectations in terms of not just where we're at in D.C., but where we're going and where we need to potentially go overall in this country with our HIV response. And here in D.C., we're not talking about just piddling around the margins. We're talking about how do we fundamentally change the level, the effectiveness, and the impact of our HIV response here locally. And I think most of us in this room know that to do that requires a multi-sectoral response. It requires a lot more than just government. It requires civil society. It requires families. It requires individuals. But today I'm going to focus on talking sort of from a government perspective, because I think fundamentally there are some key elements that government at a local level and at a federal level must provide to help make all those other elements of the response as effective as possible. So our young people here today, you might have thought, okay, this is an HIV/AIDS talk, so we're going to get like a health class. But I think instead, and I think Dan started to allude to this as well, this is a little bit more of a good government class, actually. And I hope creatively as you listen, you can also think of it as a how to change the world class. How do you fundamentally design a world that's very different from the one we're living in right now, at least for HIV and AIDS? And then how do you help us work towards getting there? So a little bit to start off about why we must do better here in the district. And about a year ago, we launched what was the first information, the first data on the state of the epidemic in D.C. in about 5 years. This was the first AIDS report we put out in 5 years and about the first HIV report ever. And you might have seen the headlines. They've been repeated quite a lot. And what we said is we have a modern HIV epidemic here. And what we meant by modern is modern in both its scale, how big we are, excuse me, and its complexity. And I think the bottom headline here is definitely a true summary. We have, here in our small town of 600,000 people, we have the highest AIDS rates in the country. And even when you compare us to other big cities, our rates are twice as high as New York City and nearly 5 times as high as Detroit. So we're in a state of the epidemic that's just not okay. And when we project what we know from the people we know have been diagnosed with HIV, we get to estimates that between 3 to 5% of the entire adult population of the district is already living with HIV. 3 to 5%. Well, that's worse than a lot of places in the world. That's worse than a lot of places that the PEPFAR, the President's Emergency Plan that has been focusing on the international response to HIV for the last 5 years, work in routinely. So we really have to grapple with this. But we have another level of complexity that we have to grapple with along with those high rates. And that is we have probably the most complex epidemic of anywhere in the world. When we look at the modes of transmission, we have it all. So we find that about a quarter of new HIV cases are occurring among men who have sex with men. We have about 15% still related to injection drug use. And we have about 40% related to heterosexual sex. So we can't afford to do just one thing. We have to address all those variable epidemics that are going on. As part of that, we also found a little bit more from our data that are really important. We have the complexity of having a large racial health disparity here. While about 55% of our residents are black, about 80% of our HIV cases here in the city are black. We also found out that despite what adults like to say a lot, this is not just a young person's epidemic. In fact, most of our new cases of HIV are happening in 30 and 40-year-olds. We have nearly as many new diagnoses in 50-year-olds and older as in 30-year-olds and younger. What does that mean? Does it mean young people aren't important? No. It means the absolute reverse. It means in all of our programming and our services and our teaching and our discussions with young people, we need to prepare all of you to have not just the information and the skills and the insights, but the ideas and the creativity to be able to deal with HIV not just till you're 25, but until you're 35 and 45 and 55, a lifetime of an effective response. So with that, what are we trying to do? And what I'm going to do is I'm going to go a little bit through what's happening here locally at DC, but also compare and contrast that to what has or hasn't been happening at the federal level, both internationally and domestically. So one of the first things I get asked when people know what we're trying to do is they say, well, what makes now so different? Clearly this epidemic of HIV in the district didn't happen overnight. Clearly there have been a lot of talented people trying to change the course. And clearly there have been a lot of dedicated HIV providers, several of whom are in the audience today, that have been working day in and day out to make a difference. So what's so new about now? And I say there's a few new things, actually, that are really, really important. In addition to the data, really knowing what we're dealing with, I think there's three themes that I want to address and sort of give a few examples of what's different and why it matters. Three themes are leadership, coordination, and working towards scale and impact. So leadership. I think we've talked about this a little bit, but not enough. Leadership matters. It matters, it matters, it matters. And not just in the ways you might think. This is one of our HIV test cards that we're using in some of our high crime areas as part of the social services intervention to get people into services that are regularly available. And you notice our mayor is first and forefront on the front of the card saying, listen, I'm asking you to get an HIV test. But beyond visibility, there are huge areas where leadership matters in the day-to-day business of making us able to get things done. And when Mayor Fenty hired me, I think he gave me a few directives really quickly, which is go fast. You know, we're already behind. Don't go it alone. And he's been supportive of a lot of innovative partnerships that we're laying the ground for to make a difference. And most importantly, set the bar high. The status quo is just not okay. I'll talk a little bit in the next sections about, how that translates to day-to-day business. But I think first to compare and contrast a little bit with the federal government response then. And I'll come back from my PEPFAR experience to the same thing. Leadership matters. And presidential leadership of the highest level makes a huge difference. President Bush's leadership on the PEPFAR and the International Response Initiative has been groundbreaking because it has really forced all of the federal agencies that work overseas to work on HIV and AIDS to prioritize achieving impact on HIV. It says, I don't care what other priorities you have as an agency, HIV has got to be one of them, and I'm going to check, and I'm going to know if it's working. I look forward to, I hope, the same level of leadership for our domestic response now, because I think we've seen the impact that federal level presidential leadership can have in our response abroad. And now there's an opportunity to, I think, model and reinvigorate that back home. And I was at a meeting on Monday where President-elect Barack Obama did a great job of giving a video address where he, in fact, said, now's the time not only to continue to commit ourselves to PEPFAR and the international response, but to recommit ourselves to the response here back home. So I said, let's start in D.C. So coordination, what does that really matter? Well, coordination is one of these things that in government you have opportunity to do in a different way because you get sort of to have a bird's eye view of a lot that's going on, not just one activity or another. Certainly, this is where leadership makes a huge difference. One of the mayor's mandates is coordination across government agencies. And then when you talk about coordination, you know, we talk oftentimes about how, well, coordination can reduce duplication and it can increase efficiency. But I think there's a really important other thing to keep in mind is without coordination, you have missed opportunities. And I think that's tragically where we want to avoid. And when we talk about working across a lot of government agencies, this is what we want to do. We want to minimize our ability, or the missed opportunities to make a difference. So we have some formal and some informal collaborations that come from these mandates of the mayor. One is some formal cross-agency working groups. One on child health, one on prison and jail reentry. Excuse me. And this really makes a difference because these formal groups report quarterly to the mayor on what progress they're actually making, what activities we're going to do and what progress we're actually making. And this allows a really creative time to take these mandates even further. One of the best examples is last year. We started doing a really innovative screening program with high school kids, where we went to high schools, went to a couple of high schools, and offered confidential sexually transmitted disease screening, just pee in a cup, urine-based screening, to everyone in the school. And kids could choose not to participate, but what we found from the schools where we offered this is there were really high rates of participation, and scarily enough, between 10 and 14% of the kids that day we showed up had an undiagnosed, untreated STD that they didn't know about. And that, you know, those findings were like, wow, that means there's a lot of need out there that we don't want to miss the opportunity to meet. Well, we reported back on this to the mayor's CAPSTAT group on child health, and he said, wow, that's huge. Yeah, we need to make sure to make this service accessible across our high schools, not just for a couple. And so, but more than that, you know, it's 5 weeks until the Summer Youth Employment Program starts, where we're going to have like 15,000 kids coming for a 3-day orientation. It's like 5 weeks. You can screen those 15,000 kids in 5 weeks, right? We're like, all right, yes. And we were able to rapidly bring partners together to set up STD screening as an opportunity at the Summer Youth Employment and screen several thousand kids. That's a level of will and leadership that you don't find a lot, actually. And we try to play that coordination out across strengthening our planning capacities and across just our day-to-day business with community partners and prioritizing linkages in who gets funded and who doesn't get funded. Tell us who your partner is and how you're going to co-manage clients to help make things better, as well as encouraging in our capacity building program some ward-based collaborations and planning on where to go next. So what does the coordination look like at the federal side? Well, one of the things that's really good about the federal response is I think the federal government recognizes that change happens at a local level, that impact happens at the person-to-person level and not in an ivory tower somewhere. And as that, about 85% of our funding here in the district comes from core federal grants. The problem is those core federal grants come from about 4 different agencies as about 14 separate grants and grant applications on 7 different fiscal years, each with their own reporting cycle, planning cycle, strategic description, monitoring and evaluation, and never the paths of any of those cross. Now, for folks who've been working with government for a long time, the usual reaction is, yeah, well, that's normal. And it is. Unfortunately, it is normal. This is what our expectations have become. But the cheating insight is, it's normal, but it doesn't have to be, because I've seen it work differently. And where I've seen it work differently has been with PEPFAR. One of the key things that PEPFAR did is it mandated that we had a global AIDS coordinator. And it said, wow, you know, we have between 8 and 12 federal agencies in any given country that we're at that are all doing some smattering of HIV programs. So we don't want to take away the identity or the importance of those different government agencies. We don't want basket funding in just one pot and it all goes out. We want to keep the comparative advantage of those different agencies However, we want that programming to make sense together. And what it meant for me, I was living in Zimbabwe at the time as our CDC director for Zimbabwe, both pre-PEPFAR and post-PEPFAR. And what it meant is that rather than my local partners who were trying to have that day-to-day impact on the ground, having to spend their time coordinating me and my U.S. government counterparts in the USAID, in the military, etc., instead it said, you know what, I'm going to place the burden on you U.S. government agencies, federal agencies, to coordinate amongst each other so that takes some of the workload off the local partners and allows them to do their programs. Not only that, it makes sure all of our resources work well together. So now that I'm at local level back here in the States, I said, you know, I know a different way that would free up some of my time to focus on programs rather than focusing on the feds, but also hopefully could help us rationalize how all these programs fit together much more effectively for a higher impact. Finally, third approach that we're really focusing here on the district is scale and impact. And I wish it would go unsaid that accountability is part of that, but I didn't think it goes unsaid, so I put it up here on the slides just so none of us forgot about it. Now here in DC, as I've described with the epidemic, you know, we have a high volume, high complexity epidemic. We have to be able to reach large numbers of people over their lifetime with really important services. So we're starting to shift our entire approach to sort of planning and thinking about how do we get those services to scale. We've shifted in our latest prevention funding from most of our risk reduction, behavior change programs being individual level interventions to being group level and community level interventions, because we just can't do this one by one only. We are looking at how we streamline and develop efficiencies and approaches, knowing that if we are successful in all the things we're trying to do, we will eventually have to be doing more. But what that means is we want to make everything work well to begin with. And importantly, here at the local level, we want to know what the impact is across the district, not just across a single project or across a single funding stream. So just a little bit of a highlight, and I'm happy to get into any questions about our actual services as we go on. One of the ways we're looking at scale and impact is sort of looking at core services. Now, interestingly enough, for a lot of our planning processes that have been really sort of promoted and designed by our technical federal agencies, we do a lot of talking about populations at risk and ranking priority populations at risk. And here's just an example of some of the populations at risk. And you start to look at it and you realize not only could a lot of people fit into more than one category, but there are a whole lot of boxes just up on this graph here. And sometimes if you're not careful, that can mean that you forget about scale and impact and you pay too much attention to a fragmented individual response to every single box there. That's different for every single box. But I think what we're finding is there are certain core elements, core services that everybody's got to have access to. And how they access them and how you make those meaningful and some of the specifics do need to be tailored. But importantly, a lot of the core services have to be there as a basis for other things as well. And I think these are some of the services that you might recognize that are just fundamentals. Counseling and testing, knowing your HIV status rather than the idea of your HIV status. ARV treatment, if you're going to be on antiretroviral treatment, making sure it's effective and you get the health benefits of doing it, not doing it halfway. Dealing with people in terms of how they relate to other people in their lives, whether it's a boyfriend, a girlfriend, a husband, a wife, a spouse, a partner, or their social support network. What is the stability in the relationships that empower people or detract from coping with HIV prevention or HIV treatment on a day-to-day basis? And we think here in the district, as the government role, we have a role not only in ensuring that services are out there, that they're accessible, but that they're used. And here's one quick example of one of the projects we did this year to try to make sure that we got more people into the antiretroviral treatment programs that were available. And this was an advertising campaign that went from January through August. It was It's Free to Treat Your HIV campaign to make sure that people knew that even if they didn't have health insurance or money, that antiretroviral drug treatment was available. And believe it or not, as soon as we started running this campaign, and it had a lot of facets, we tripled monthly enrollment in our ADAP program. So we had a direct impact at getting more and more people into treatment. And not only that, we found people who, it wasn't just that they thought they couldn't afford treatment. We had people calling us and calling the mayor's hotline, which was the contact point for this, calling us who actually didn't know that there was such a thing as HIV treatment that would save their lives. So we have a long ways to go in really helping people use the services that are out there. I'm not going to go through all these initiatives right now, but just I'll scroll through these couple of slides, and you see there's a lot of different components, because again, with our complex epidemic, we can't afford to focus on just one thing. HIV counseling and testing is a huge component of what we're doing. Condom distribution and condom availability. We're one of only 2 public sector condom distribution programs in the entire United States, which might sound a little odd to those of you working internationally. We are really excited because this past year we got to fill out our toolbox finally for substance abuse and harm reduction by being able to fund for the first time needle exchange programs as part of comprehensive services. And we're placing a real priority on building community level capacity and engagement on a day-to-day basis on the HIV response. So lastly, what are some of my thoughts or lessons from the federal level on terms of on scale and impact and accountability? What would help me be more effective on a day-to-day basis here in DC? And I think number one, I'll come back to my beginning theme, high expectations. PEPFAR set incredibly high expectations. For folks that aren't familiar with it, 5 years ago, there were less than 45,000 people on antiretroviral therapy in sub-Saharan Africa. And at the beginning of PEPFAR, they said, you know what, in 5 years, we're going to go from 45,000 to 2 million people on this highly complicated treatment. And people thought they were crazy, crazy. Well, it turns out Monday, PEPFAR was able to announce that they've hit their targets, and it's not even 5 years yet, that there are more than 2 million people now on effective antiretroviral treatment in Africa that would have been dead, probably, otherwise. So they set what was an unrealistic goal, and then we met it. Now, earlier this year, I had this reflection when CDC launched its new incidence estimates, which is the estimate of how many people got newly infected in the past year with HIV in this country. And the previous estimates had been 40,000 new infections across the United States a year, and the new estimates were approximately 60,000 new infections a year. But the initial talking point or response about this is, but it's not that the number of new infections went up, it's just that we got better at counting them. So this is really stable. It's really, it's stable. And I thought, oh my goodness, when did we decide that 40,000 people contracting HIV newly each year is okay? 40,000 was never okay. 60,000 is even less okay. And so I think in our domestic response, we have to change our expectations. And I look forward to our young people hopefully changing your entire expectation so that we can work towards it. I think expecting that we must live in a world that has AIDS is the wrong expectation. We need to expect that a world without AIDS is possible and then do everything we can to get there, to change it. So if people try to sell you the line that this is just how it is, I say, no, we need to raise expectations, and we need federal leadership in raising those expectations to complement our local leadership in that. Second lesson, I think, from PEPFAR, funding to scale. A lot of times we've been constrained with our federal funding to say, well, how do we spend what we have, as opposed to saying, what do we need to make a difference, and what kind of difference would that be? Interestingly, with PEPFAR, the initial ask was $15 billion over 5 years. What a lot of people don't know is that $9 billion of that were monies that we were already spending. We were already spending in over 100 countries for HIV programming. It wasn't that there was no HIV programming before PEPFAR. What PEPFAR did is they didn't try to just carve up the pie in a new way. They baked a whole new pie. So they added $6 billion of new monies to that $9 billion and said, this $6 billion, we're not going to take anything away from anything that's already there, but we're going to use these $6 billion to figure out what we can achieve that would fundamentally change the state of the response for the entire world. New investments to fund impact as opposed to just carving up the pie and piddling at the margins. I think the third thought on how the federal response can help our local response for scale and impact has to do with innovation. One thing that made PEPFAR a little bit easy some places is sometimes we weren't building on much. There wasn't much of a status quo there to change, and we could actually build things from scratch. Here, domestically, we have the absolute positive history of we're not starting from scratch. We have a lot of really good programs, a lot of really good services that have developed over the last almost 30 years. But at the same time, we find that over time, our epidemic has totally changed. Our ability to treat and to prevent HIV has totally changed. Our healthcare system has started to totally change, and there's been a lot of evolution in our healthcare system over the last 20 years. But a lot of our structures and policies haven't fundamentally changed. And I think it's time to sort of say, what does it take to make an impact now? And one of the things I'm very excited, I think, about the upcoming administration is the prominent role that the healthcare system has taken in the dialogue and reforming the healthcare system. Because when we talk about HIV and HIV programming, it needs to be talked about part and parcel of the healthcare system rather than a standalone event. So the better we build our healthcare system, the more tools we have to enhance our HIV response effectiveness here at home. So what do we know here in DC? Well, this is what I know. I know we've got a modern epidemic and we need to build a modern response. I know that because this epidemic is not just about youth, we need to get grown-ups involved, but we also need to ask that our youth start planning for their entire lives and figuring out how we change the face of this epidemic. We have to deal with the epidemic we have now, not the one we had a decade ago, not the one we wish we had, but what we are stuck with right now based on the data. And that requires, keeping what's working and building on it, innovating where it needs to be, but keeping in mind scale and impact. And to help us do that locally, I hope that there'll be opportunities to update the federal supports too, because I think we have a more broad portfolio of what actually can work these days. And so I hope to see that take light. So thank you.
Thank you very much, Shannon. We're going to move into a question and comment period. First, I neglected in my opening remarks to mention my daughter, Mehret Morrison, who's here, who's in the 7th grade. And Dan kindly opened the way by embarrassing Cassie, and so I will do the same with Mehret. I also neglected to mention that we are doing this event in partnership with the Kaiser Family Foundation. Alicia Carbow from the Kaiser Family Foundation is here today with us. Jennifer Cates, another member of Kaiser, couldn't be with us today, but was very instrumental in talking to Shannon and trying to plan this event. Kaiser is a premier organization in the United States in the collection and analysis and guidance on data and policies pertaining to health. And we're very proud and very grateful for the partnership that we've been able to create with Kaiser over the last 7 years. Many people helped us put this event together, too, particularly Suzanne Brundage, Karen Meacham, our colleagues, Eric Little, Heather Texera, Kate Hoffler, who is here today with us. We're going to move to questions and comments, and what we're going to do is we have microphones that will be brought to you. I want to welcome all the kids here from Capitol Hill Day School to pose a question or comment. What we'll do is we'll do a round, and then we'll come back to our speakers. You can put your question to the city administrator, to Dan Tangarini as well. Is that correct? You can put your question or comment to Shannon Hayter. So who would like to pose a few initial comments and questions? Please just raise your hand, and when we come to you, we'll bring the microphone to you. Just introduce yourself and where you're from, and then try to be brief in your question and comment. Right behind Eric.
Is this on? Yes. Thank you for a most interesting presentation. I have lived in the district now for over 30 years, but I've been working in AIDS for 20 years, so I found this of particular relevance. The question I have to ask is that you're talking about HIV/AIDS as a crisis. We also have a crisis of teenage pregnancy. You, here in the district, you say your title is with the HIV/AIDS administration. Is AIDS being treated in a silo fashion, or is it in fact being integrated across other health services? And a sort of footnote question, if we were in Africa with a 5% prevalence rate, we would have billboards all over the city. I travel back and forth from northwest to northeast regularly. I haven't seen a single advertisement talking about HIV/AIDS.
Thank you. Take some other questions. Come on, we need some Capitol Hill Day School students. Please, we have two children. Please introduce yourself. Stand up and introduce yourself.
My name's Gretchen. I have a question. You're looking at just D.C. Are you also looking at other states in America and like other countries?
Thank you, Gretchen. Back behind.
I'm Bridget Carmichael, and I was wondering, how did DC, we were talking about DC in America, but how did we compare with the other, with the rest of the world on an international level?
Great. Let's take two more. Right here. Right here. Yeah. And then we'll come back to you.
My name's Edward Stewart. I was wondering, in a certain case, aren't you kind of to a strong extent educating the wrong people at this particular point? I mean, I think what you're doing is really good. I think it's really, really awesome what you're doing for DC. But for us, we've had our HIV talks ever since 5th grade, and I know there are a lot of other places in DC where there have not been as kind of regular sex ed classes as we have. I'm just wondering, isn't there another way to educate other parts of the people, other schools who maybe haven't had quite as much education in this kind of field as we have?
Okay. Right in front here. Then we'll come back to you.
My name is Isaac, and I have a question for Dr. Hayter, and it is, how did you become interested in your field of work?
Okay, and let's take one more. 2 rows back. We'll do another round, and we'll get more questions, comments.
Hi, I'm Lydia. I have a question for Dr. Hayter, too. Okay, so you talk about educating this youth, but when we grow up, do you have a plan for reminding us to educate our youth?
Okay, that's quite a bill there. Shannon.
So I might jump around a little bit between the different questions. I think there are a couple of different questions about how do we compare to other areas in D.C. or other areas in the States, how do we compare to the nation, and also how do we compare to other countries across the world. In fact, we do have a lot invested in knowing what's going on, not just in D.C., but the greater Washington area. And we take care of a certain amount of services in Southern Maryland and Northern Virginia and West Virginia as well. And they have their own complexities to the epidemic. Our rates are still higher than in the suburbs, but the suburban rates are not, really, really low. And I think some of the challenges that are even more marked in some of our surrounding areas is a lot of our newer immigrants don't live in D.C. proper, they live in our surrounding areas. So some of the language, some of the culture, some of the figuring out how to use the system issues are very different in our suburbs, or more of a challenge in our suburbs than they are even here in D.C. How do we compare to the rest of the United States? Well, I think this is where, Dan mentioned we sort of have to compare ourselves to other big cities sometimes. Because I think if you start comparing D.C. to, like, North Dakota, it doesn't make a lot of sense. Wouldn't make sense for jobs, wouldn't make sense for the, rate of rent you pay, and doesn't make sense for HIV. But when we compare ourselves to other big cities, we're still higher, twice as high as New York City. But importantly, and unfortunately, I suspect that a lot of urban southern cities might be starting to follow our pattern, both with the rates going up and the complexity going up. And I hope that we can help them learn what to do now to keep from following in our footsteps. In terms of the rest of the world, our rates are if you look at sort of rates overall, any rate above 1% of the overall population is considered extremely high. When you sort of just go into a general population, you've got 1 in 100 or more people who are living with HIV. And so again, our rates are between 3 and 5%. So our rates are higher than Ethiopia. They are higher than most of West Africa. They are on par with Congo and Angola and Central Africa. So, you know, we hear a lot about AIDS in Africa, but we don't hear a lot about AIDS back at home here. And so I hope we can restart those conversations. Education, education, education. Some great education questions, both about education now in the school systems and the education going forward, generation to generation. And I think this issue is who else do we need to reach in terms of young people, and other schools is key. There is a large initiative with DC Public Schools to have standard health and HIV curriculums across all of the public schools and into the charter schools as well. Because one of the things you highlight is our school system is a huge tool for equity. We can ensure through the school system that every child gets a certain basic level of information in schools and access to these kind of teachings, whether you go to a good school or bad school. Now, you're in a wonderful school that has been actively doing this for a long time, and you're right, that's great. So we are very much collaborating with the DC Public Schools to say, how do we get other schools to have at least a certain level of access to this kind of education and information, and I think thinking about solutions that they might not have right now. And in terms of reminding you all when you get older about how to talk to your kids, I expect that you guys are going to be figuring out how to do that and how to remind each other and how to hopefully be in a whole different situation. One of the areas we are focusing on in new programs is actually a program called Parents Matter that we're rolling out with the foster care system first, that actually is directed to parents. And it teaches them how to talk to their kids about really sensitive issues. So instead of us talking to the kids, we say, you know, hard stuff, sex, drugs, and rock and roll, they come up a lot. And so if you're uncomfortable talking about those things, that's pretty normal. Let's teach you how to do it and teach you what makes a difference. And so I think working on those parent-child communication priorities hopefully will lend to, you know, passing it on as well. And I think back to the initial programs, what about teen pregnancy, what about silos, and what about invisibility? Definitely our goal is not to be working in isolation, and as I think from the first coordination effort, it's definitely not the mayor's goal either. And our child health working group that's cross-administration really grapples with these issues comprehensively to try to start to integrate the relevant aspects with each other. I have to say nationally, we have a ways to go just within our reproductive health approaches and our teen pregnancy approaches. We've had a few decades of teen pregnancy prevention that have focused a lot on oral contraceptives, or not oral contraceptives but injectables, and not sexually transmitted diseases as well. Not necessarily relationship choices, abstinence, partnership building, and also condoms, but only on the pregnancy prevention side. So I think we can learn from each other as fields and really work towards sort of a new way to integrate. And in terms of invisibility, I think we are absolutely in recognition that this needs to be more prominent in daily life. We have had several campaigns launch over this year. One was the It's Free to Treat Our HIV campaign that was on metros and buses and radios and TVs. Second are with some of our partners that some we support and some they've done, and we've said, rah, rah, keep going. One is there's been a youth campaign called Real Talk. Again, you might have seen it because it's being advertised towards youth. In a lot of the places where youth hang out, and it has some text messaging component, and Metro Teen AIDS is really the group that has developed that and expanding on that. And then Whitman Walker Clinic is doing a Project Red, which is just started recently. we're looking to build on all those things, to have a really concerted 5-year social marketing initiative that builds on itself by promoting not just the idea of HIV, but what can you do about it? What are the actions you can take day to day to change our epidemic?
Do you want to say anything about how you came to this, Isaac's question?
Oh, how did I come to this? That's a great question. Let's see. It's a long story because I'm really old now. But, you know, I think there's some things I really like. I like to do a lot of things. I feel privileged to have a chance to make a difference. And I think probably what was really critical is, you know, when I was in high school, I really liked the idea of medicine, like being a doctor and all that, but I didn't really know how that fit in with all my other interests. And I ended up going to college in the San Francisco area in the 80s, which was the beginning of the major HIV epidemic there, and medical school in New York City in the early 90s, which was a real explosion of the HIV epidemic there, and really was interested in international stuff as well. And I think health, and HIV is part of that, but health is something that we find cross-cuts all of our existence, from our social level to our jobs and health insurance to how we deal with our family to how we think about the future. And I really just sort of came to feel like, wow, what a privilege to be able to be involved somehow and hopefully get some sort of skills in an issue and an area that sort of affects everybody's lives. So I guess that's how I ended up doing what I do here.
Great. If I can add a couple of quick things. Shannon said earlier that this is going to be more like a good government class than a health class. And one of the key things that we've tried to incorporate into the Fenty administration is this notion of best practices. And I like to quote the poet E. E. Cummings, who said that great poets don't copy, they steal. And that's why we stole Shannon from the CDC. But the idea is to look across the nation and, frankly, look across the world, because we can't be so arrogant as to assume that we have the solutions. And in a problem like HIV/AIDS in the city, in the District of Columbia, it's clear that the solutions probably are not domestic solutions. They're going to be solutions like in Zimbabwe, where Shannon was able to see a nearly 25% reduction in new incidences of AIDS. That's the kind of best practice that we would like to see incorporated into the District of Columbia. These are global best practices, and that's why a dialogue today between us is so important. Another important issue that Shannon mentioned was this notion of breaking down the stovepipes and operating really as a team and recognizing that these problems are beyond a single administration. You saw that horrifying list of 15 grants. They're beyond a single grant. These are problems that require everyone to come around and look at that problem and figure out a way that they can contribute to it. And that's another hallmark of the Fenty administration, bringing our cabinet together and having us work as a team. That's why we fought so hard to gain full control over the school system, because we wouldn't be able to actually put this city on a trajectory, a positive future trajectory, unless we really coordinated the school efforts with all our other efforts, public safety, public health, and public education.
Thank you. Okay, let's take another round of comments and questions. There's a gentleman right here, a woman here, and we'll come over to this side of the room. Yes, sir.
Hello, my name's Charles Farthing. I'm from Merck, but I've been working for HIV for 25 years, and Shannon, you look very young to me. Thank you for your talk. But I would like to take up with what I don't think you got a chance to answer was the First Lady's question about billboards. When I was in London at the very beginning of the epidemic in the 80s, I think England really clamped down the size of their epidemic compared to many European countries by having a huge television program. In fact, the Scandinavians did even better a few years earlier with having condoms down the sides of their buses in Copenhagen in '83. And in Uganda, another country I've worked, they had huge billboards all around the city, as was referred to, and they really affected the size of their epidemic. And you never see that in this country, almost never. All you see is advertisements for antiretroviral drugs from pharmaceutical companies. But when we attacked smoking, we had huge billboards we had fantastic television advertisements. Why don't we do that? And why can't we throw one of our billions of dollars to doing that and addressing the domestic prevention?
Hi, my name is Beth Turrison, and I'm from URC, and I work with international HIV and AIDS programs. I would be interested in knowing what you found was one of the most successful practices or experiences that you had working with HIV and AIDS programs in Zimbabwe that you feel could be applied to the situation here in D.C. and domestically in general.
Hi, I'm Danielle Davis with Gilead Sciences. And my question relates to hepatitis and how hepatitis screening and treatment will fit into the overall HIV plan, particularly when it comes to mono and co-infected individuals.
Thank you. Let's get a couple of kids. Mary Beth, would you like to ask a question?
My previous life, I did billboards for family planning. My question is any component of Dr. Hayter's realm peer counseling or peer education? Because I think you have an audience of prospective peer counselors.
Thank you. Thank you. Grace, did you have your hand up? No. Okay. Do we have any other kids with hands up? Let's right here. Andrew? Identify yourself and ask your question.
I'm Andrew, and I was wondering, I saw MSM. What does that mean again? I just forgot. Okay.
All right.
Okay. And we have a hand up in the back. And then we'll come to Nick. Oh, sorry. Yes. No, go ahead.
Sorry.
Owen.
Hi, I'm Owen Ryan with the Gates Foundation. I just was wondering if you could talk briefly about what makes the transmission unique here as opposed to some of the other cities you were mentioning. And also, we've been focusing on youth, but you mentioned at the beginning of your presentation about the older trend in transmission. If you could just comment on that as well. Thanks.
Let's go to Nick. Oh, come on, you can't go back. Let's get one more kid. Okay, Shelby, come on.
I'm Shelby. What's IDU?
Excellent.
Okay, why don't we come back to Shannon, okay? We've got a number of questions.
Good questions. Thanks for the clarification. So I'm going to be the translator here because I spoke too much HIV speak or doctor speak. IDU, injection drug users, so people who have injected drugs, which of course, because you're dealing with blood and you're dealing with needles, is a really easy way to transmit HIV if you share needles with somebody else. MSM, men who have sex with men. So sometimes people say, okay, gay men, but not all men who have sex with men think they're gay. So gay, bisexual, and just men who have sex with men, because that's just another way we track. Just like men and women having sex, heterosexual sex. It's sort of where we have to figure out how to focus our responses. Peer activities. Sure, peer leadership is a really good component, a good core component of programs. I think one of our leaders in this is really Metro Teen AIDS, is a local on-the-ground organization that trains young people to really become leaders in their own social network or their own school on HIV response, and we support them to help do that as well. Hepatitis, where does hepatitis fit in? It's now part of our administration. So for about a year, our HIV/AIDS administration has included tuberculosis and adult hepatitis and sexually transmitted diseases, and we think that's a really good mix. So in terms of adult viral hepatitis here, so hepatitis you can get through either injecting drugs or through sex, we're really at the beginning of our programs, and we're starting to map out right now how severe is hepatitis here in the district, and who does it affect, and what services are and aren't available so that we can work on filling those gaps. Billboards. Yes, but what we want is effective billboards. And also I think billboards are the most visible, but they're not the most way that people get their information these days. We actually have a whole portfolio of ways people get their information on a day-to-day basis. a lot more people getting their information through texts and virtually or on Facebook, not just through billboards. And so we sort of have to figure out how we get enough information out there to make a difference, but we don't put all of our eggs in one advertisement basket, so to speak. How we diversify but still have enough presence to have an impact. And some of that is targeting messages. We just started a 5-year really social marketing initiative to help us figure out how to do this not just once, but over the next 5 years. Because I think when we think about campaigns that have been really effective, it's not just about visibility. It's also about what you're saying and how that relates to actions and services and behaviors. So, for example, some of our really effective other public health campaigns that stay in a lot of our minds. This is your brain on drugs. You know, everybody who's old enough to have seen that probably, you think of the commercial right now, right? That wasn't just a good idea. That was the basis, that campaign was based on a whole lot of market research and a whole lot of market testing of that message before it went live across the country. Similarly, Nike. I can guarantee you these gorgeous Nike commercials that you see that make you want to go out and buy shoes and start running again and get all that going, those aren't cooked up in the back room of somebody having a good idea and just going out for visibility. Those are based on really hardcore strategic market research that says this investment is going to pay off. In the early days of HIV, we did a lot of that. And then, interestingly enough, both domestically and internationally, as we went on in the epidemic, we started talking about HIV as if it's only about good ideas. And just sitting around the table, if I have a good idea, we're going to launch a campaign with it. And not looking at the evidence base then of saying, well, does somebody else think that's a good idea? And how does that affect what they think, what they do, the choices they make? And so we're trying to back up a little bit and go back to best practices for advertising so that we can have not just one campaign, but a whole series of layered, effective, synergistic campaigns over time. And then I guess my favorite question, what were some of our most successful programs in Zimbabwe or lessons learned from Zimbabwe that resonate for me in my memory? There are so many. I think some things are cross-cutting, and some things were counterintuitive, and so maybe those are things that stick with me. For those of you who don't know, Zimbabwe, I've worked there off and on for about 15 years, but really I worked very intensively between 2001 and 2006. And Zimbabwe's been undergoing really hard times between 2001 and 2006. It was, called probably appropriately an outpost of tyranny by our current State Department. There have been massive political crises that have led to horrible economic crises and the whole collapse of the economy, and then horrible humanitarian crises with starvation and with HIV and AIDS. So in a context like that is where we started to build our HIV response. And I mean, all of us there. I was there at CDC, but we worked together with the Ministry of Health, the local governments, the local community-based organizations. That was the collective we. And intuitively, what people often say is, well, when the world's falling apart, how can you expect anyone to take HIV seriously? HIV is so far off that if you can't send your kids to school and you can't figure out how to pay the rent and you can't get a job and you don't know how you're going to eat, how can HIV be a priority? How can you imagine to have any impact on HIV whatsoever? And yet the reality showed something else, which was by scaling up, even in this horrible context, effective quality HIV services. We went during that time from a HIV prevalence rate from 24% to 17%, and we went from fewer than 500 people on antiretroviral treatment to 85,000 people on antiretroviral treatment. Wasn't easy. But I think importantly on the decreased rates, and we did do a lot of analysis to show a lot of that decreased rates were clearly due to decreased transmission, and particularly the younger generation. When we did sort of our age analysis, it was the young groups that were staying HIV-free. And we sort of found out, in a situation where the world is falling apart, sometimes HIV is the most controllable thing there is. on an individual level in your life. It can be easier to choose certain choices for yourself and the people you care about to keep you protected from HIV than to figure out how to pay the rent for a month, than to figure out how you're going to deal with some horrible death in the family. So I think that is probably the most important lesson learned, that even in a time of hardship and competing needs, HIV actually can be a priority. And not only that, it can be an empowering priority. Because in the Zimbabwe context, someone who's laying in bed dying of AIDS or caring for someone who isn't about to be marching in the streets to overturn the government. They've got other things to deal with. Versus that same person who has done everything they can to drag their loved one 5 kilometers back and forth a whole bunch of times to the clinic in a wheelbarrow to make sure they get on antiretroviral treatment as soon as possible, and sees that person almost come back from the dead in terms of regaining their health and their livelihood. You know what? That kind of empowerment, that kind of seeing direct results based on your efforts is generally not limited to only health or only HIV. That kind of accomplishment can translate to the rest of your life. So it's my long-winded insight.
Did you want to answer Owen's question about the social, the age demographics?
Oh, thank you. Yeah, so age demographics and what makes, transmission here, any different in DC. I think a few things to comment on. I'm trying to think the best summary here. When we look at, sort of patterns of behavior, I think all over the world, you see very similar patterns of behavior all over the world. And sometimes in terms of what gets you to a really high rate, it's when and how HIV was introduced and the social networks about how quickly it spreads among each other. And I think certainly one thing that's important for any epidemic is if people didn't think they were at risk because they thought HIV was somebody else's disease, oftentimes they don't take precautions to protect themselves or protect the people they care about. And I have a feeling that that contributed a lot here in terms of, what sort of got us to this level. We're starting to do a lot more intensive evaluation of behavioral aspects, so the why. Our surveillance data is sort of the what's going on. And then we can do smaller studies about the why. What's the state of people's behaviors and relationships and things like that. We do have some data on our heterosexual epidemic. We'll have data soon on our men who have sex with men epidemic, and then data a year after on our IDU epidemic. Some of the things we found with our heterosexual study was really profound, I think. Number one is, the people we studied were folks who were sexually active, and their average age was 30, which again sort of mirrors our epidemic here. And we started asking them questions about their behaviors and their relationships and things like that. And we found out a few things. People are having sex. That's why we were talking to them. Not very many people were using condoms. So 80% of the people weren't using condoms. And we said, well, but let's talk about the real stuff. Let's talk about relationships. And we talked, and 70% of the folks we were surveying, and this is almost 1,000 people, we said, are you in a regular, committed relationship? Do you have one person that you're in a regular, committed relationship with? And 70% of them said, yeah, I do. We didn't care if they called that a husband or a wife or a boyfriend or a girlfriend, but a regular, committed relationship. And we thought, well, that's sort of, okay, 30 years old, that sort of makes sense. That's a good age for a regular, committed relationship. And we said, well, tell us a little bit more. Of those of you in this regular, committed relationship, do you know your partner's HIV status? Half the people said, it's never come up, I have no idea. You think, but we live in D.C., not in North Dakota. This is a big deal. You're in a regular, committed relationship, but you can't have a talk about HIV or get a test, or what kind of commitment is that? So, well, okay, let's ask the next question then. We said, okay, those of you in this regular, committed relationship, you have someone you're calling a boyfriend or a girlfriend or a husband or a wife. You think your partner's cheating on you? You think your partner has other, partners at the same time that they're with you? 45% of men and 55% of women said, yeah, I'm pretty sure that my partner has someone else other than me. And I think that's going to bring us to a lot of fundamental discussions here, because I think it starts to say, what are we as individuals expecting from the people we trust and care about? If we can't expect or ask or demand that the person that I think I love is going to be willing to talk to me about HIV, be able to talk to me about these sensitive issues, and in fact be willing to commit to me, here in D.C., where we have this added, problem of not just heartbreak, but of, HIV, well, that's a problem. And that's a problem that we have to start to grapple with here, is having these really, serious relationship dialogues and figuring out what do people want to do.
Let's take one more round at the back wall. You've been very patient. And we'll come up.
Hi, my name is Netta Smnani. I'm from Congressional Quarterly. I just have a quick question about some of your cross-cutting programs. HIV/AIDS tends to be either domestically or internationally, first and foremost, an issue of poverty. And in this case, as in most cases, I believe a UN report came out the other day that showed a strong gender linkage. And in D.C., there's the added racial aspect to it. So that's one question. What is the Fenty administration doing to address these three very specific program characteristics? And then my second question would be, is there a nutritional aspect to your interventions? Because, as most people know, HIV/AIDS interventional programs definitely meet that added benefit.
Thank you. Right here, the gentleman, and then next to him.
Good afternoon. My name is Pavel de Jesus. I'm with the Office of the Governor of Puerto Rico here in D.C. Two quick questions. One, can you talk a little bit about what you're doing with your Medicaid program? Because so much of the funding for HIV/AIDS care and treatment is actually linked to Medicaid. Two, could you talk about translating your leadership vision for hard-to-talk-to communities, be those faith communities or folks on the street, so on and so forth. And third, just so you know, we don't generally say it publicly, but from our perspective, you're sort of ahead of the curve in comparison to where we are, and we look to many of the things that D.C. is now doing as sort of our first steps towards improving our own situation. So.
Thank you. Could you hand the microphone to the person just to your right?
Right.
Thank you.
Thanks. Hi, I'm Leah Stern. I'm interested, we've talked a lot about what PEPFAR can teach us domestically. I'm interested in what, if anything, you think domestic or local programs can teach PEPFAR programs.
Thank you. Leanne? Right here. Stand up there.
My name's Leanne. Okay. How long is an average person, supposed to live if they have HIV/AIDS?
Thank you. Mary Beth?
And before our bus demands our attention, I want to thank you very much for having such a large group from Capitol Hill Day School and for offering us such an intelligent and diversified informational session. Thank you.
Miss Jeremy, and I'm wondering if women can get AIDS or HIV from having sex with other women.
I'm Horace, and I was wondering if, men have AIDS more than women, or women have AIDS more than men.
Thank you. Grace, did you have your hand up?
My name is Grace. I was wondering, why did all of those grants not work as effectively as we hoped or thought that they were going to?
Let's take one more question. Right here, please.
Hi, I'm Rachel, and I was wondering, I have a question for Dr. Hader, and I was wondering if if Zambia and DC were the only places you've been teaching about this. Have you been teaching other children about the same things in different countries?
Okay, so I'm going to start with the last questions, that group of them first. So starting with men and women, gender differences, and who's got HIV, who's getting HIV. The world over, there are actually more women than men with HIV, but it's pretty equal. When you look at our data in our epidemic here in the district, about 70% of the folks living with HIV/AIDS are men, and about 30% are women. That said, we have certain wards in the city where, again, the epidemic is shifting and we're getting more and more transmission among heterosexuals, and so we have certain wards in the city where it's almost equal, where it's like 45% women and 55% men. So all of those numbers can sort of shift over time, and we need to follow them to understand who we need to reach out to. In terms of, can women give HIV to other women, or can women get HIV from other women? The answer is yes. You know, essentially, we know how you get HIV, and it comes from body fluids sharing body fluids. That said, it's a lot more likely, but a lot less likely than women getting HIV from a man or from a needle or things like that. But that said, and you know, I'm just going to speak straight talk here because I think it's really important. Part of the reason when we're talking about HIV, a lot of times we, use these sort of sterile, generic terms like men who have sex with men or women who have sex with women, as opposed to gay or lesbian, is just because someone identifies as a certain sexuality. I'm identifying as gay, I'm identifying as lesbian. Sometimes people still have sex with the other gender. So it's important to talk about the behaviors and the risks and the body fluid transmission issues, and not just about sexual identity. Lifespan, great question. And this is one of the areas where we've been this is a celebration actually on World AIDS Day of how different the world is now from what it was 27 years ago, if not just 13 years ago. Which is, how long do people live? Well, we knew before there was any HIV treatment that your average person was actually infected with HIV for about 10 years before they ever got sick. But then once they got sick, they'd usually die within 2 years of getting sick. So the average lifespan was 10 or 12 years. The fantastic thing is with treatment, complicated as though treatment can be, and it's not, a very fun thing to have to go to the doctor every 3 months no matter what, for the rest of your life and get your blood drawn and everything. But with the drugs we have now, as far as we know, people can live indefinitely. So people who are able to get on the right drugs and take their drugs perfectly every day, which is a really hard thing, they can, if they're already sick, not only regain their health, rebuild their immune system, but if they're healthy, to stay healthy. And so I think that's a wonderful thing. We've only had this kind of treatment for about 13 years. And so we've only seen people sort of surviving 13 or 15 years based on treatment, but we expect that lifespan is going to be a lot longer. Money, money, money. Why haven't all those grants been more effective? And I would say that, there are a lot of services that have been provided for a lot of people, and that's really important. But we need to not only achieve more with the dollars that are there, but also get more dollars for over time, doing more overall, because I think we got a lot more to do. One of the keys to, I think, effectively using every single dollar has to do with what Dan mentioned about best practices and about data and information, about not what you want to happen or not what you wish that dollar would buy or achieve, but what's the effect it's actually happening, achieving. And that can be easier to say than to actually measure. That said, a lot of people over time haven't bothered to measure it because they're putting so much blood, sweat, and tears into the service that they really don't want to know if it's not working, because it's really hard to deal with. And so that's one of the areas where data for decision making and continually asking ourselves over and over and over, not only are we getting the right services to the right people in the right scale, but are they having the impact that we're trying for? Because if the hardcore answer ends up being no matter how much we believe that program is popular and exciting and good, we got to shift. We've got to try something else. So we absolutely need to maximize every dollar we get so that we can be better at asking for more. Last one I think was, what does the domestic or the local epidemics have to inform on the international front? And I think what's really interesting about that question is I think in most audiences the expectation is our response abroad is exactly how we share our, domestic lessons learned with the rest of the world. And that seems to be a really intuitive thing for people, to think that, we're helping the rest of the world. And we have been. And I have to say that, just sort of looking back, there have been a lot of hardcore lessons learned and interventions developed here in the States that we didn't have to repeat the hard lessons abroad when we started really expanding our international programs. I think the best example of this is treatment adherence, which is the idea that if you're going to take these HIV medications, you have to take them the right way every day, because if you don't, they stop working, and they stop working forever. So you've sort of got, a shot at doing it right, and particularly in countries where they might not have 2 or 3 different drugs they could take, but they got one shot. We learned the hard way that, something we've always known in healthcare is a lot of people don't take their medications right every day. But with HIV, we can't afford to let that happen. And so when we built all these programs abroad with PEPFAR, we started from day one with great adherence programs that really emphasized this idea that we need to support people to take their medicines the right way every day, no matter what. And with that, as well as some of the other programs out there, I think we've had tremendous success in a lot of our treatment programs abroad, with success rates actually higher than what we've achieved here at home in a lot of populations.
Yeah, real quick, I think that's the last good government lesson, and you heard Dr. Hayter kind of refer to it, and that's the fact that it's very important to have good data and do the analysis, set goals, and actually measure your performance against them. And I think that's a kind of one of the understated points of really the work that Dr. Hayter and the HIV/AIDS Administration has really been focusing on, and that is getting that good data. Because we don't know if the billboard or the communication is going to work unless we know who we're trying to target it to. We don't know whether that grant is going to be effective unless we know where the incidence is increasing or where we're seeing progress and the incidence is decreasing, so we can understand whether our interaction has had any benefit. And so that's a key aspect of, frankly, doing the work well, is actually getting good data, understanding the epidemic, understanding who's in the epidemic, who's likely to be the next person, and trying to get ahead of that curve and try to address their problems ahead of time.
Thank you. We're at the end of our hour. I know there are some of you who have questions that perhaps we could follow up after this, but we do need to close because we're under some time pressures, particularly for the students who are with us. Shannon and Dan, I want to thank you so much for coming and being with us this afternoon and for your continued leadership.